Firstly, I thank the overseas alumni for inviting me to deliver this lecture, and as everybody, I'm also very much privileged to do this presentation in front of my most respected teacher chairing the session. So I've been asked to discuss the management of preeclamptic toxemia, or we call it the hypertensive disorders of pregnancy. Group of disorders where maximal uncertainties and controversies prevail. Uncertainties with regards to etiology, pathophysiology, the classification, uncertainties with regards to categorizing the severity, management, and so on. But still, it's an important group of disease because hypertensive disorders of pregnancy affect about 10% of all pregnant women around the world. In Asia and Africa, nearly 1/10 of the deaths, maternal deaths, are associated with hypertensive disorders of pregnancy. And 1/4 of all maternal deaths in Latin America have been associated with this disease or its complication. And in the UK, it is the second leading cause of direct maternal deaths, second only to thromboembolic disorders. So can we avoid or minimize the morbidity and mortality? We have to, because it is a necessary step towards achievement of the Millennium Development Goals. If you can remember, the target 5A of the Millennium Development Goal put down by the WHO is to reduce the maternal mortality ratio by 3/4 between 1990 and 2015. And the majority of deaths related to hypertensive disorders of pregnancy can be avoided by providing timely and effective care to women presenting with such complications of pregnancy. So what is the accepted classification? A lot of people have classified it differently, but the commonly accepted classification is you classify it as gestational hypertension. We are moving away from calling it pregnancy-induced hypertension. We call it gestational hypertension, chronic hypertension, preeclampsia and eclampsia, and superimposed preeclampsia, that is superimposed on a pre-existing hypertension. And this is the classification by the National High Blood Pressure Education Program Working Group. So we will define these classifications. That is, the gestational hypertension is new onset hypertension in pregnancy presenting after 20 weeks of gestation without proteinuria, and the blood pressure returns back to normal less than 12 weeks postpartum. Chronic hypertension, a blood pressure of more than 140/90 before pregnancy or diagnosed before 20 weeks of gestation, not attributable to gestational trophoblastic disease. Where in gestational trophoblastic disease, it is possible that you can get high blood pressure before 20 weeks, or hypertension first diagnosed after 20 weeks of gestation, but persistent after 12 weeks of postpartum. So this is a retrospective diagnosis. Then preeclampsia and eclampsia, blood pressure more than 140/90 after 20 weeks of gestation in a woman with previously normal blood pressure with significant proteinuria, and eclampsia is defined as seizure that cannot be attributed to other causes in a woman with preeclampsia. So what is superimposed preeclampsia? That is a new onset of someone who has already got a chronic hypertension with new onset significant proteinuria, but no proteinuria, where she has not had proteinuria before 20 weeks, or a sudden increase in proteinuria or blood pressure or platelet count less than 100,000 per microliter with hypertension and proteinuria before 20 weeks. So the pathogenesis is also confusing, but earlier it was said that it was a disease of theories, but we are now understanding it more and more. Basically, it is placental dysfunction or something to do with early presentation, where oxidative stress, genetic factors, immune factors play a role. But what we have to understand is it is related to disturbance in the presentation at the beginning of pregnancy, followed by generalized inflammation and progressive vascular endothelial damage. Although the pathophysical changes, that is the disordered presentation, exist from the very beginning of pregnancy, hypertension and proteinuria usually become apparent in the second half of pregnancy. So the next one is, how do we classify the severity? We classify it as mild and severe based on the severity in the mother, that is severe hypertension, heavy proteinuria, or substantial maternal organ dysfunction, or you can classify it as according to the time of onset, early onset, late onset. Early is considered severe, or depending on the morbidity as an independent, fetal morbidity as an independent criteria. But any practicing clinician will consider all these three things when he or she is classifying the severity. But the important thing to understand is the progression from mild to severe can be very rapid, unexpected, and occasionally fulminant. So what are the aims of management? If possible, prevent it. Whether we can prevent it or not, we will discuss. Early recognition of complications and severity, minimizing further pregnancy-related complications, and avoiding unnecessary prematurity and maximizing the maternal and infant survival. So where do we get the evidence for current practice and recommendations? The primary source of evidence for the recommendations, obviously, is from the Cochrane Systematic Review of Randomized Controlled Trials. Many bodies have put forward the recommendations and the evidence. The WHO also has a detailed document on prevention and treatment of preeclampsia and eclampsia. And from this point onwards, I will discuss some management options and recommendations based on this evidence until the bell rings, maybe. So, rest for prevention. First, we will discuss prevention. Rest for prevention for preeclampsia and its complications. Advice to rest at home is not recommended as an intervention for primary prevention of preeclampsia and hypertensive disorders of pregnancy in women considered to be at high risk of developing this condition. Strict bed rest is not recommended for improving pregnancy outcome in women with hypertension, with or without proteinuria in pregnancy. Right. So the dietary salt restriction for prevention of preeclampsia, clearly restriction in dietary salt intake during pregnancy with the aim of preventing the development of preeclampsia and its complication is currently not recommended. Calcium supplementation, which has been extensively studied. In areas where dietary calcium intake is low, calcium supplementation during pregnancy is recommended for the prevention of preeclampsia in all women, but especially in those who are at a high risk of developing preeclampsia. Vitamin D supplementation again is not recommended for the prevention of preeclampsia. Antioxidants have been extensively studied because one of the basic underlying pathology behind the disordered presentation may be oxidative stresses and so on. So individual or combined vitamin C and E supplementation during pregnancy, it is also has been shown not to be very effective in preventing preeclampsia. When it comes to antiplatelet therapy, you will always, everybody will remember the CLASP study, and following that so many randomized control studies have been published. And the current thought is low dose aspirin, that is 75 milligrams aspirin, is recommended for prevention of preeclampsia and its related complication in women at high risk of developing the condition. And we have to remember that if we are going to start low dose aspirin, it has to be started before 20 weeks of gestation, and if possible as early as possible. And there is no point in starting after 20 weeks of gestation. So what are these high risk situations? At least we should remember previous preeclampsia, diabetes complicating pregnancy, chronic hypertension, renal disease, autoimmune disease, and multiple pregnancies. At least for these group of people, we should start low dose aspirin as a measure for prevention. Then we'll come to antihypertensive treatment for mild and moderate hypertension during pregnancy. Available evidence are controversial again, as there are potential harms and benefits associated with both lines of action. So mild and moderate hypertension without proteinuria, usually we don't start antihypertensive treatment. But for severe hypertension, as most maternal deaths are related to hypertensive disorders most maternal deaths related to hypertensive disorders are associated with complications of uncontrolled severe blood pressure. It is recommended that in this group of patients we should start them on antihypertensive drugs. Then the next is the magnesium sulfate for prevention and treatment of severe preeclampsia. Everyone will remember the MAGPIE trial, but after that so many trials have come up, and magnesium sulfate is currently recommended. It has been compared with several drugs, and it is currently strongly recommended for the prevention of eclampsia in women with severe preeclampsia in preference to other anticonvulsant drugs. And also as a treatment of eclampsia, magnesium sulfate is recommended for the treatment of women, women with eclampsia in preference to other anticonvulsants. And also it is recommended that the full intravenous or intramuscular magnesium sulfate regimens are recommended. Full in the sense not only you give the oral, the loading dose, you have to continue with the infusion as well, and it is recommended and treatment for the treatment of eclampsia. For settings where there is difficulty in continuing the full regimen, at least we should give the loading dose, and after that the patient may be transferred to a facility where the other monitoring and other facilities, tertiary facilities are available. Then when it comes to delivery of the fetus, that is interventionist versus expectant care for severe preeclampsia before term, as we know delivery is the ultimate treatment. Gestational age, we have to consider these factors like the gestational age, when the fetus is not viable or unlikely to achieve viability within the next 1 or 2 weeks, or the viability of fetus before 34 weeks and between 34 and 36 weeks and at term. So severe preeclampsia at a gestational age when the fetus is not viable or unlikely to achieve viability within the next 1 or 2 weeks, induction of labor is recommended to deliver the fetus. In women with severe preeclampsia where the fetus is viable and before 34 weeks of gestation, a policy of expectant management is recommended, provided that uncontrolled maternal hypertension, increased maternal organ dysfunction or fetal distress are absent and can be monitored closely. In women with severe preeclampsia with a viable fetus between 34 and 36 weeks, a policy of expectant management may be recommended, provided that again uncontrolled maternal hypertension and increased maternal organ dysfunction and the fetal distress are absent or can be monitored. Of course, when it comes to term, you don't have to worry too much. We have to always deliver the fetus, that is after 37 completed weeks. Then when it comes to prevention and treatment of postpartum hypertension in women treated with antihypertensive drugs antenatally, continued antihypertensive treatment in the postpartum period is recommended until the blood pressure settles. And the treatment with antihypertensive drug is recommended for severe postpartum hypertension, where a small subset of people will develop postpartum hypertension where they don't have severe hypertension in the antepartum period. Lastly, I would like to mention, you can go on telling about the recommendations, but lastly, I would like to mention that we have to always recognize the risk of postpartum hemorrhage. We usually don't recognize the risk of postpartum hemorrhage in a patient with pregnancy-induced hypertension or this group of diseases. the approximate odds ratio without any complications are almost 4 to 5. That is the risk of developing postpartum hemorrhage. So if a patient, whether she is delivered vaginally or whether she is delivered by a cesarean section, due to a hypertensive disorder of pregnancy, we have to be ready for a postpartum hemorrhage, which itself is the biggest killer in Sri Lanka. Thank you.